Hello. Right, my dear lovely friends. Very good morning to all of you. And I hope you had a sound sleep. And I'm really pumped up and motivated by looking at your so many messages. So this simply indicates better that you are really dedicated, you are really focused, and you are actually trying to achieve the best scores for you. Right, so just a quick recap. What we were trying to discuss yesterday in pediatric surgery, if we just focus on the indexing, what all we have done till now, then in this indexing beta, just a moment, yeah. So if we take a look at this indexing in pediatric surgery, then we have talked about this cleft lip and palate. There we saw the different images of cleft lip, what is unilateral, what is bilateral, what is partial, what is complete, why these things occur, what can be the problems to the baby. Lip can be diagnosed on antenatal ultrasound after 18 weeks. And in the treatment, we have to do plastic surgical reconstruction for cleft lip, 3 months, 3 to 5 months, Millard and Waddell. For soft palate, 6 months, and hard palate, 12 to 15 months. Then we talked about different swellings in the neck. Just a quick recap. There is a thyroglossal cyst, which is exactly in the middle of the neck. There is a branchial cyst, which is in the upper part of the neck on the anterior border of sternomastoid. There is a branchial fistula in the lower part of the neck. That is again on the anterior border of sternomastoid. These are the remnants of second branchial cleft, and the branchial cleft, the branchial arches, the pouches. That is something which you are going to read in your anatomy embryology classes. Right. Then we talked about cystic hygroma, which is in the posterior triangle of neck. This is something which is a lymphatic collection, so brilliantly transluminant swelling. Then we talked something related to esophageal atresia, when God has not formed some part of esophagus. What can be the different types? Which anomalies can be associated? What happens during pregnancy? How these babies actually present to you immediately after birth? What can be the risk in this baby? What is the first test you do? What is the first investigation you do? What is the best investigation, and how you are going to treat these esophageal atresias on day 1, day 2 of life? And you also saw that if the two ends of esophagus were far, then you were waiting for 4 to 6 weeks, you were giving feeding jejunostomy, and then you were reassessing whether the two ends of esophagus have come close or not. Then we moved down into the abdomen, and here we talked about the epigastric stories, the duodenal atresia, annular pancreas, and the hypertrophic pyloric stenosis. Duodenal atresia, the absence of some part of the duodenum due to failure of fusion of foregut midgut. You know, if there is a traffic jam at the duodenal level, especially if the jam is below the opening of common bile duct, then the patient is going to present with bilious vomiting. But if there is a traffic jam above the level of opening of common bile duct, for example, pyloric obstructions, then they are going to present with non-bilious vomiting. Non-bilious vomiting. Just give me a moment. Just give me a moment. Right. So, in this duodenal atresia, we saw that bilious vomiting. We also discussed the concept when you will be getting a single bubble, double bubble, triple bubble, multiple central and multiple peripheral. एक बार हो जाए बेटा. Let us quickly recap that. Single bubble, double, triple, multiple central, multiple peripheral. Perfect. Wonderful. That's really great. Now, we saw that how we are going to treat these duodenal atresias just by connecting the duodenum with the duodenum, that is duodenoduodenostomy. When there is a big gap, then we are just going to bring that innocent guy, the jejunum, and we'll be doing a duodenojejanostomy. Rarely we can find this annular pancreas type of story. Annular means ring-like. Sometimes a ring of pancreatic tissue surrounds the duodenum. The presentation is almost the same as duodenal atresia, so the findings and the treatment is also same as duodenal atresia. Then hypertrophic pyloric stenosis, that was something which was not atresia, it was just a stenosis of the pylorus. So this used to take few days for hypertrophy of the pyloric musculature, so the baby did not present immediately after birth. It took some time for the baby, maybe around 2 weeks time, and generally at third week of life, these babies used to present with non-bilious projectile vomiting, acid was getting lost, metabolic alkalosis. Initially the urine was alkaline, but because of severe dehydration due to vomitings, the kidneys started conserving sodium in water, which led to excretion of potassium H ions in urine, paradoxical aciduria. First, in these babies, we have to correct the hydration and the electrolyte imbalance. Then we can do the ultrasound. Once the diagnosis is made, we can do a pneumatic balloon dilatation, or we can do the Ramstedt seromyotomy. Then we moved from this epigastric story into the right hypochondrium. Here in the right hypochondrium, we tried to understand the concept of this biliary channel especially. We saw that God has given liver to all of us in the right upper abdomen, and the job of one of the important jobs of liver is to produce bile, and there is a defined flow rate at which the bile is being produced inside the liver. This bile is responsible for digestion of fats, and fats are coming into your intestine, whatever fats you are taking in diet. That means the God had to deliver this bile into your intestine to help digestion of fats coming in the intestine. And so God had made some biliary channels, the right left hepatic duct, the common hepatic duct, the cystic duct and gallbladder, and the common bile duct. Gallbladder is something which is not forming the bile, it is just for the storage of bile, because God knows the human nature. Sometimes, especially if we talk about India, then in the northern parts of India like Punjab, the people do have a habit of eating a lot of butter. Especially in the morning, they eat paratha with butter, right? So when somebody is taking bulky butter inside, then whatever bile is coming from the biliary channels, that may not be sufficient to digest this bulky butter. So God made the gallbladder, that even if you take a bulky butter, don't worry, the gallbladder will contract and will throw huge amount of bile, which will help in emulsification of this bulky butter and aid in the digestion of fats. We discussed the simple concept there, that whenever there is a traffic jam type of situation in the biliary channels, what is going to happen to the patient? If there is a traffic jam in the biliary channels, the bile is not going to come into the intestine. If bile is not coming into the intestine, then how will this butter be digested? So buttery stools or steatorrhea, we can say malabsorption of fats. Plus, whenever there is a traffic jam in the biliary channels, the proximal people are going to get dilated, and all this bile will be congested inside the liver, where the bile is going to get mixed with the blood, and bile in blood is jaundice. That is what is obstructive jaundice or a surgical jaundice. Now, the only thing which is required to understand by all of us, beta, to make things very, very simple. If we talk, what can be the stories in pediatric age group, what can be the stories in adult age group, what can be the stories in elderly age group? So simple. Pediatric age group, God may not form the biliary channels at all. Sometimes there may be dilatations of the biliary channels, which can create a traffic jam type of situation like choledochal cyst. Adults, there might be some stones in the biliary channels, the common bile duct stones. There may be some inflammation of the bile duct like cholangitis. There may be some stricture developing in the bile duct. Elderly people, there may be malignancy in the bile duct, cholangiocarcinoma. So any traffic jam situation in the biliary channels, you know, the presentation will be steatorrhea, malabsorption and jaundice, right? Generally, if no age is specified and you are asked to comment that which investigation you will be doing for identifying or seeing these biliary channels, then your answer should be MRCP, magnetic resonance cholangiopancreatography. This is a non-invasive investigation which can show the biliary channels nicely. Whenever any diagnostic or therapeutic procedure has to be done in biliary channels, we need some instrument to do the diagnostic or therapeutic procedures, which is not possible on MRI. So in these cases, we do ERCP. We pass our endoscope from the mouth, take this endoscope into the duodenum, and then through the side channel of this endoscope, we can pass some instruments into the common bile duct or the pancreatic duct and do diagnostic and therapeutic procedures. That is why for diagnostic and therapeutic procedures, we prefer ERCP. Yesterday, we talked about a condition of biliary atresia, which was absence of biliary channels, type 1, type 2, type 3. Type 1, there is no CBD. Type 2, there is no CBD, there is no CHD. And type 3, there is no CBD, no CHD, and no right and left hepatic duct. That means in biliary atresia, whatever is the type, there is no common bile duct. And if there is no common bile duct, beta, if you're doing a ERCP, you are not having the bile duct where you can push the contrast. So ERCP is not possible in biliary atresias. MRI is something which is not possible in small babies because they keep on moving and we get a lot of motion artifacts. So in biliary atresia, to see the biliary channels, we have to do a HIDA scan, which is an isotope scan, which is injected into the peripheral vein. This isotope goes inside the body, inside the circulation, goes into the liver, excreted by the hepatocytes, and then it comes into the biliary channels. And it can show us the type of biliary atresia. That is why investigation of choice for biliary atresia was HIDA scan and not ERCP or MRCP. We also discussed that how, if God has not made the biliary channels, how you, second God, how you will bring the bile from the liver into the intestine. We know we have got one innocent guy, and that is the jejunum. एक ही शरीफ आदमी है बेटा GIT में. जब मन करता है सर्जन्स का, तब वो बेचारे जेजुनम की मदद ले लेते हैं और जेजुनम को जहां चाहे वहां ले जा सकते हैं. बेचारा फ्रीली मोबाइल होता है, इसलिए जगह जगह ले जाके हम जेजुनम की एनास्टोमोसिस करते रहते हैं. कल हमने हेपेटिक डक्ट की बात की. Jejunum is something which is freely mobile, and you surgeons, you take the help of this jejunum and you can just take it here and there and you can do different anastomosis, connect this jejunum with different people. Yesterday we connected this jejunum with the common hepatic duct, then we used to call it as hepaticojejunostomy. If you were connecting the jejunum directly into the liver, we called it as Kasai operation or hepaticoportoenterostomy. Later on today in our discussions, we might be talking that we are connecting the jejunum with the stomach. So that will be a gastrojejunostomy. Maybe in next 3-4 days, we'll be discussing that we can even connect this jejunum to the pancreatic duct, and then we'll call it as pancreaticojejunostomy, right? So I hope you got this concept nicely. In Kasai operation, if we are connecting the jejunum directly into the liver, since there are no biliary channels, that means the jejunum will only be able to drain the bile which would be lying close to the jejunum. The bile which is not lying close to the jejunum, that bile will be getting congested inside the liver, which will put pressure on the hepatocytes, and maybe in 2 years, 3 years time, these hepatocytes will fail. Liver will fail, and eventually we'll end up in doing a liver transplant. If biliary atresias babies are not treated, they generally die in 2 to 3 years of age, right? Nowadays, beta, there are a lot of babies from foreign countries who are coming to India for liver transplant for biliary atresia, especially the Central Asian countries, especially the Pakistan, Afghanistan. There are a lot of babies who are coming to India for getting this liver transplant done, right? I hope this small story, this small summary, this small understanding of the concepts may help you on 17th of December like anything for any pathology related to biliary channels. Right. Give me a moment. Right, beta. So now let's move to another pathology related to this right hypochondrium, that is choledochal cyst, right? Let's take a look. The name itself implies chole means bile, doco means duct, and cyst is simply a dilatation. That means here we are going to talk about some dilatations, abnormal dilatations in the biliary channels. This is cystic dilatation of the biliary channels. The exact cause why the biliary channels get dilated is not known, but it is said that probably it is due to anomalous pancreatico-biliary duct junction. Now, what is this anomalous pancreatico-biliary duct junction? Just to remind you, beta, that we have been talking that this is suppose the pancreas, this is suppose the duodenum. We know that the bile duct is opening like this. We know the pancreatic duct is opening like this. Now, if you focus on this particular area, the junction of the bile duct and the pancreatic duct, sometimes this junction may be abnormal, because of which there might be some traffic jam situation, which will lead to dilatation in the biliary channels. And we can find these different types of dilatation in the biliary channels, right? However, this is just a hypothesis. The exact cause is not known. Now, the Todani Sahab classified these choledochal cysts into 5 types. And on 4th of June 2022, we got a question where we were supposed to identify what is this type of choledochal cyst. So let us try to draw the different types of choledochal cyst, and I would like you to use this entire space for drawing the different types of choledochal cyst, right? So let's use this space. First, beta, what I'll be doing is I'll be drawing the normal story. The normal story, suppose this is the liver. So I've just tried to draw the normal livers. This is the right hepatic, this is the left hepatic, this is the common hepatic. Here would be the cystic duct, and then there would be the bile duct. And this bile duct will be joining with the pancreatic duct, right? So this story would be something which is normal. Okay. Now sometimes what will happen, beta? There may be abnormal dilatation in these biliary channels. Now here I would like to tell you, beta, type 1 is the most common, and basically what happens in type 1, there is a diffuse dilatation of the CBD. There is a diffuse dilatation of the CBD. So the story is something like this. Right? Type 1, where there is diffuse dilatation of CBD. This is type 1 choledochal cyst, right? Now, if we take a look at another type, beta, herein, this thing what I've drawn looks to be normal. Type 2 choledochal cyst is when there is eccentric dilatation of the CBD above the pancreas. Now here, please note beta that this what I have drawn, this is not normal. This is pathological, right? This is actually an eccentric dilatation from the CBD. Pancreas is lying in this area. So this dilatation is above the pancreas. If I try to draw this, suppose this is the pancreas beta, and if you take a look at the duct here, this something like this. So here what you are seeing is dilatation of the CBD above the pancreas. This is type 2. Then another case beta. This is a right hepatic, this is a left hepatic, this is the common hepatic, this is the cystic, and this is the gallbladder. Now here, this is the CBD, and here, this is the pancreatic duct. Here lies the pancreas. This is the CBD coming here, and suppose this is the pancreatic duct here, right? Now type 3 is actually a dilatation in the CBD within the pancreas. This was asked on 4th of June. Intrapancreatic dilatation of CBD. This is type 3. Actually, they gave the images and they asked which of the following images showing a type 3 choledochal cyst, right? So you were supposed to just identify where is the dilatation. If this dilatation is in the CBD, and that too in that part of the CBD which is within the pancreas, then it is a type 3 choledochal cyst. So this is what is a type 3. Once again, you can appreciate this beta. This is dilatation in the CBD within the pancreas. This is type 3 choledochal cyst. Okay. Then type 4 beta. Type 4 we can divide into two types, 4A and 4B. Before we move on to the type 4, let me give you a quick recap here. This is something which is normal. You are not seeing any dilatation in the biliary channels, right? This is the most common type where you are seeing diffuse dilatation of the common bile duct. Here what you are seeing is a eccentric dilatation from the CBD above the level of pancreas. Here what you are seeing, this is a dilatation of the CBD within the pancreas, right? That means type 1, type 2 and type 3 beta, they are involving the common bile duct only. If we go to the type 4 and type 5, we'll see that it is not only the common bile duct, but it is something which is involving the hepatic ducts also, the right left hepatic ducts and the common hepatic ducts. So if we just try to understand that story as well, suppose this is the right hepatic, this is the left hepatic, this is the common hepatic, this is the cystic, this is the gallbladder here, this is the common bile duct, and here this is the pancreatic duct. Now 4A is something where you find dilatations in the CBD in both intrahepatic as well as extrahepatic ducts. Dilatation in the hepatic ducts, both intrahepatic matlab liver के अंदर, intrahepatic ducts as well as extrahepatic ducts. This is 4A. This is the right hepatic, this is the left hepatic, this is the common hepatic, this is the cystic, this is the gallbladder, this is the common bile duct, and here this is the pancreatic duct. If suppose there are dilatations which involve only the extrahepatic ducts, this is called as type 4B. And if suppose this is the right hepatic, this is the left hepatic, this is the common hepatic, this is the cystic, this is the gallbladder, this is the common bile duct, and suppose here is the pancreatic duct. If suppose there are dilatations which involve only the intrahepatic ducts, then we call it as type 5. So this is how we can classify the different types of choledochal cysts. Let's see them once again, beta. The first story, this is normal story. The different types of choledochal cyst. Chole means bile, doco means duct, cyst is dilatation. So whenever there are dilatations in the biliary channels. Now type 1, as we can see, beta, this is a diffuse dilatation of CBD. Type 2, when there is dilatation from the CBD above the pancreas. Type 3, when there is dilatation of the CBD within the pancreas. Type 4A, when there is dilatation which involve both intrahepatic as well as extrahepatic. Type 4B, which involve only the extrahepatic, and type 5, which involve only the intrahepatic, right? So just to differentiate the gallbladder here so that you do not get confused, what I'll do is I'll color the gallbladder differently. Suppose I use this color for gallbladder. This what you are seeing here is the gallbladder. Now, if we take a look once again, beta, at the different types, this is something which is normal. Type 1 is a diffuse dilatation of CBD. Type 2 is an eccentric dilatation from CBD above the pancreas. Type 3 is dilatation of CBD within the pancreas. Type 4A, this involves dilatations in both intrahepatic as well as extrahepatic ducts. 4B, dilatations only in extrahepatic ducts. 5, dilatations involving only the intrahepatic ducts. Right, beta? So I hope these are a bit clear in your mind that how we can classify the different types of choledochal cysts. Todani was the person who classified these choledochal cysts into 5 types, where type 1, type 2 and type 3, they involve the common bile duct. Type 4 and type 5, they involve the hepatic ducts. Most common is type 1, and this is diffuse dilatation of common bile duct. Type 2 is eccentric dilatation of CBD above the pancreas. Type 3, dilatation of CBD within the pancreas. This is also called as कोलिडोकोसील. क्या बोलते बेटा इसको? कोलिडोकोसील. Type 4A, both intra and extrahepatic ducts. 4B, only extrahepatic duct. 5, only intrahepatic ducts. And type 5 is also called as Carolese disease. Type 5 is also called as Carolese disease, right? I'll show you some images of Carolese disease. These are MRCP pictures of various choledochal cysts beta. Herein, let me see if I can remove these colors. Yeah. Will I be having this somewhere else? Let me see. Okay, no issues. I was just trying to search a picture where I would not have made these markings. This is the MRCP pictures beta, what you're seeing here. In this particular picture, if you can see, this is the right hepatic duct, this is the left hepatic duct, this is the common hepatic duct, this is the cystic duct, and here is the gallbladder. And here was the CBD. And there was a diffuse dilatation in the CBD, which was demonstrating it as type 1. This image, what you're seeing beta, this is a type 2, where this actually is the CBD. This is the pancreatic duct, and there was a eccentric dilatation from the CBD above the level of pancreas. So this is type 2. Another image, this is the common bile duct, this is the pancreatic duct, and there is a dilatation of CBD within the pancreas. This is type 3. Another image where you are seeing dilatations within the intrahepatic as well as extrahepatic. So this was 4A. Now beta, in Carolese disease, what happens? This is simply dilatation of intrahepatic duct. Now, if you carefully take a look at this image beta, this outline what you're seeing, this is the liver. And can you see some hypodense areas in the liver? These hypodense areas, what you're seeing, these are actually cysts inside the liver in relation to these hepatic ducts. This is how Carolese disease looks like on a CT scan. When we are doing the ultrasound beta, this whole story, what you're seeing, this is liver. And in this, you are seeing some black shadows. These are the cysts, what you're seeing. And whenever we are noticing these cysts, if you carefully take a look beta, can you see there is a central white dot in these cysts? There is a central white dot what we are seeing, right? Here also. When we did a Doppler, we found that there is actually color flow in these dots. And when we trace these vessels, we found that this is because of some branch of the portal vein. That means in these cysts, there is some branch of the portal vein which is coming. This is what was called as central dot sign, which was asked in NEET PD long back. So central dot sign can be seen in Caroli's disease. This is the actual specimen of liver in Caroli's disease, right? Important thing to note, beta, this is how these multiple cysts are present inside the liver. These cysts, choledochal cyst, whether it is type 1, 2, 3, 4, 5, they can become malignant. And malignancy developing in the biliary channels is cholangiocarcinoma. Chole means bile, angio means vessel, and carcinoma is carcinoma. So malignancy in the biliary channel is cholangiocarcinoma, right? Since they can become malignant, beta, as a doctor, you are the second god. If you come across a patient who is having multiple cysts inside the liver, and if that is Caroli's disease or a choledochal cyst, that means this can become cancer. And in these cases, you cannot leave them inside the patient. You have to remove them. If you have to remove these cysts from the liver, you can very well understand it would be really difficult to remove them one by one. एक एक करके बेटा इन cyst को निकालना मुश्किल ही नहीं, नामुमकिन होगा. So because of this reason, if suppose these cysts are involving both the lobes of the liver, then we have to remove the entire liver of this patient and we have to do a liver transplant for Caroli's disease. If these cysts are confined to one lobe of the liver, then we can simply do a lobectomy for these Caroli's disease, right? Okay. So in Caroli's disease, beta, there is a central dot sign which actually corresponds to the portal vein. Now let us see that how these patients can present to us. Like these patients can come to us in OPD or they can come to us in emergency. Herein, I have just tried to explain that how these choledochal cysts can create problems. Suppose beta, this what you are seeing, this is the right hepatic, this is the left hepatic, this is the common hepatic, this what you are seeing is the cystic duct, and this here what you are seeing, suppose this is the gallbladder, right? Now if we are talking about the commonest choledochal cyst, that is type 1, we know in type 1 there is diffuse dilatation of the common bile duct. There is diffuse dilatation of the common bile duct, right? This, just to demarcate, this is the gallbladder story, right beta? Now just try to focus here. What can happen in this patient? There is a diffuse dilatation of the common bile duct. You know that the bile is coming from the liver into these biliary channels. Bile would be going into the gallbladder also. So sometimes what can happen? The bile may cause stasis in this cyst. Suppose the bile starts staying in the cyst. Suppose I say that the bile has started staying in the cyst. There is a possibility that this cyst may keep on enlarging, somewhat like this. Now, if the cyst is enlarging something like this, there is further risk of biliary stasis. And this stasis of bile can create problems sometimes. If there is stasis of bile in this area, this might sometimes create a traffic jam type of situation. And you very well know, beta, if there is a traffic jam, the proximal people, they all are going to get dilated. The bile is not flowing down nicely into the intestine. The same story, steatorrhea, malabsorption, jaundice. Because of these dilatations, the baby can present with some mass in the right upper abdomen, or you can say in the right hypochondrium. Small babies, especially whenever there is any enlargement of organ inside the abdomen, these babies can present with some mass, whether it is a case of intussusception or a Wilms tumor in the kidney. Generally, if you look at the small babies, I'm pretty sure, beta, you might have got some opportunities when you would have slept with those small babies, maybe of your some siblings, newborn babies, or maybe a small baby. When that baby is sleeping, right, and you just try to examine the abdomen. If you just try to feel the abdomen, the abdominal muscles are very lax, and you can nicely feel right inside the abdomen what all is going on. We can understand, beta, these small babies would not be going to any gym, so the abdominal wall muscles would be quite lax. The abdominal muscles may not offer any resistance. That is why any organ enlargement in small babies can be felt nicely as a mass or a lump. That means these choledochal cyst babies, you can feel a mass in the right upper abdomen, right? So, generally, choledochal cyst babies can present to you with intermittent jaundice in infancy, which would be painless. Sometimes there can be pain. They can also present with a mass in the right hypochondrium. Now, why you have written intermittent? Because there is a possibility that due to biliary stasis, there would have been some obstruction, because of which the proximal people are dilating, the bile is going into the blood and jaundice. But we also know, beta, whenever there is any traffic jam situation in any tubular structure in the body, whether it is bile duct or ureter or intestine, जब in tubular structures में traffic jam होगा, proximal people are getting dilated, there would be stasis, risk of infection, stone formation in biliary channels and urinary channels. Plus, in all these situations, the proximal muscles will try to contract forcefully and they will try to throw the obstruction out. And since it is not a complete traffic jam situation in choledochal cyst, many a times when these proximal muscles contract, they are able to throw this bile into the intestine. As soon as the bile goes into the intestine, the traffic jam is cleared and the jaundice disappears. Again, there is a chance that there might be stasis in this choledochal cyst, because of which it may be creating some traffic jam type of situation. The proximal people are getting dilated, jaundice, the proximal muscles are contracting, they would be putting pressure, and with pressure this bile may be flowing down into the intestine, jaundice disappears. That is how we can find intermittent jaundice in choledochal cyst. Right, beta ji? Fine. Now, how to approach these situations? Any patient who presents to you with jaundice, what is the first investigation, beta? Very good. Any patient who presents with jaundice, look at me on the screen. Any patient who presents with jaundice, the first investigation will be liver function test. Any patient who presents with a mass or a lump in the abdomen, the first investigation will always be ultrasound. Yesterday we talked ना बेटा कि अगर कोई भी उम्र हो, बच्चे, बूढ़े और जवान, अगर पेट में गोला है तो पहला इन्वेस्टिगेशन अल्ट्रासाउंड. ठीक है? अगर पेशेंट को जॉन्डिस है तो पहला इन्वेस्टिगेशन लिवर फंक्शन टेस्ट. ये हमेशा ध्यान रखेंगे. Whenever we are talking about pathologies in the right hypochondrium, then this ultrasound and liver function test, this is something which is complementary to each other. especially when we are talking about the biliary problems. So if you have done a LFT, then you do a ultrasound. If you have done ultrasound, then you do a LFT. So depending on what is given there on 17th of December, whether the examiner is focusing more on jaundice or the examiner is focusing more on the mass, you will choose accordingly, right? Fine. Now, once this LFT is done, if the baby was having jaundice, the liver function test would be deranged. If the baby had a mass, ultrasound would have shown that mass. How? This ultrasound will show us this mass. This is what we see on ultrasound. If you carefully take a look at this beta, this is the ultrasound picture, what you're seeing. This structure, what you're seeing on ultrasound, this is the gallbladder. Here, what you're seeing beta, this should have been a tubular structure. This is common bile duct. And just beneath the common bile duct, you are seeing another tubular structure, beta G. This is the portal vein. Now, ideally, common bile duct should have been like this. But here you are seeing something. So there is dilatation here. And this is how the choledochal cyst looks like on ultrasound. Can you appreciate this dilatation in CBD beta? Fine. I repeat, this what you are seeing is the gallbladder. This is the common bile duct. This structure what you are seeing below, this is the portal vein. And you can see this dilatation in the CBD, and this is how choledochal cyst looks like on CBD, on ultrasound. However, for biliary channels, we talk that we have got investigations like ERCP, MRCP, and HEDA scan. This baby is presenting in infancy, small baby. So MRCP would be a little difficult. Can we do ERCP in this baby? Yeah, we can pass the endoscope from the mouth. It will be going through the esophagus, stomach, duodenum, and then we push the contrast into the common bile duct, and the contrast will be flowing into the common bile duct. Let us see. Yes, we can see these cysts. Now here what you're seeing beta, please have a look on the screen. This structure what you're seeing here, this is the endoscope beta. This is the endoscope. This is the endoscope. So you have taken this endoscope into the duodenum, and now you have pushed the contrast into the common bile duct from below. As the contrast is flowing here, ideally this should have been looked like a tubular structure. But what you are seeing here, you are seeing more amount of contrast in this area. This is a dilatation what you are seeing in the common bile duct. And this is how choledochal cyst looks like on ERCP. My dear lovely doctors, if you have got two investigations right in front of you, and suppose you have to choose out of these two in which investigation you are able to see the choledochal cyst better, what will you choose? Ultrasound or ERCP? Very good. You are able to see these cysts nicely on ERCP. That is why investigation of choice for these choledochal cysts is ERCP, endoscopic retrograde cholangiopancreatography. Right? You know that these choledochal cysts can create some of the other complications. And one of the major complications what can occur is cancer. So you know that you cannot leave the cyst inside. That means, my dear friends, you know that how this baby has presented to you in the OPD, intermittent jaundice, mass in the right hypochondrium, LFT ultrasound has been done, ERCP has been done, and you are able to find this cyst. Now in the treatment, because it can become cancer, you don't want to take any chances. Just a needle aspiration will not be able to remove the cyst. Even if you aspirate, you may be able to empty the cyst temporarily, but again the cyst is going to immediately refill with bile. So you have to remove this part of the common bile duct which is having the cyst. अच्छा बेटा, अगर अपन इसको रिमूव करें तो देखते हैं क्या होगा. If we are trying to remove this, oh my god, we have removed this. Now what should be done? We know that here this is the common hepatic duct. What should be done? Ideally, we should join this part with this part, right? But the problem is, when you're trying to bring this part down, this part is actually embedded inside the liver. We can see that this part is embedded inside the liver. If you try to stretch it down, then this part will come out. So we'll not be able to stretch this down, right? Then, if we try to take this part up, we know that this part is lying within the pancreas. So this is fused in the pancreas, so we cannot bring it up. That means we cannot join these two things. Now, we know that bile is coming into this area. Bile is coming here. And we want this bile to go into the intestine. And we also know that there is one person who is always ready to help us. Who is that person? Jejunum. So what we'll do the same procedure and we'll bring the jejunum here, right, and do the anastomosis. So if you are doing the anastomosis, actually in this operation we remove the gallbladder and the cystic duct also. So when we remove this gallbladder and the cystic duct, it is something like this, right? And herein, if you just try to imagine, this would be coming somewhat like this, and here you know there is a duodenum which is lying here, and then there is a jejunum. So you will connect this jejunum here, right? Here suppose this will be the stomach area, and here would be the esophagus area, something like this. So now if you try to take a look better, you have just connected the hepatic duct with the jejunum. Pancreas is lying here, pancreatic duct is opening here, food is coming here, food and pancreatic juice is coming here, food and pancreatic juice is coming here, bile is coming here. So now you are able to mix the food, pancreatic juice and the bile, right? Again you can see this is forming somewhat a letter Y. So we call it as Roux-en-Y hepatico-jejunostomy, right? So that is what we are doing for the treatment of these choledochal cysts. Roux-en-Y hepatico-jejunostomy. Or you write it like this, beta. First we have to do cyst excision. Cyst excision. And then we are simply focusing on hepatico-jejunostomy. You can write Roux-en-Y hepatico-jejunostomy as well. But for the concept, I am mentioning hepatico-jejunostomy. Right, Beta Ji? So I hope this concept is absolutely clear in your minds. Right? This is the treatment what we are doing for type 1 choledochal cyst. Now, sometimes what can happen, Beta? The story can present an emergency also. How? Sometimes, beta, when we were talking about this biliary stasis here, look at me on the screen, look at me, beta. If suppose there is a biliary stasis here, bile is staying in this area, you know that stasis is an open invitation for the bacterial party. So there is a possibility that the E. coli who are living in this particular area, now we are in the GIT, beta, and here when we are moving towards the intestines, we know that there is good amount of bacterial population. So E. coli is something which we can normally find in the biliary channels. Whenever there is a stasis of bile here, the E. coli party can start. And if E. coli party starts here, beta, we all can understand this can lead to acute inflammation. And whenever there will be acute inflammation, which would be involving the biliary channels, this is going to become a Ruber tumor Kehler-Dollar. And this whole story will get acutely inflamed, right? And there's a huge bacterial party in this. The patient will present with high-grade fever, chills and rigors, especially when we say infection in the biliary channels, cholangitis. It is not a small party. It is a huge party whole night. DJ, bang, these E. coli, they keep on banging like anything. And the patient develops high-grade fever, chills, rigors. Patient may have pain, severe pain in the right hypochondrium. And obviously, because of this party here, because of the stasis here, the proximal pressure is increasing, bile is going into the blood, jaundice, pain, fever, jaundice. Famous triad, Charcot's triad. Pain, fever, jaundice, Charcot's triad. Right, beta, can you do this with me? Pain, fever, jaundice, that is Charcot's triad. Pain, fever, jaundice, Charcot's, pain, fever, jaundice, Charcot's, pain, fever, jaundice, Charcot's, pain, fever, jaundice, Charcot's, pain, fever, jaundice, Charcot's. Can you repeat this with me, beta? Charcot's, 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 Charcot's. Yes, this is pain, fever, jaundice, right? This is a very important triad. And conceptually, beta, whenever there will be inflammation in the bile duct, whenever there will be cholangitis, reason may be any, कारण कुछ भी हो सकता है. अगर बाइल डक्ट में इन्फ्लेमेशन है, अगर कोलेंजाइटिस है, तो पेशेंट प्रेजेंट्स विद चारकोट्स triad, pain, fever, jaundice. And you are great doctors. You have a good understanding. What I am saying right now, listen to it very carefully. Whenever there is any traffic jam situation in the bile duct, if the proximal people are getting dilated, stasis, infection, acute inflammation in the bile duct, cholangitis, the patient will present with severe pain in the right hypochondrium, high-grade fever with chills and rigors, and jaundice. Pain, fever, jaundice. These patients will have this Charcot's triad. And many a times, because there is a huge party going on in the biliary channel, there is a possibility that quickly these bacteria can spread into the blood. If the bacteria goes into the blood, all over the place in the body, septicemia. Patient may go into shock-like situation, hypotension, mental confusion, pain, fever, jaundice, hypotension, mental confusion, signs of septicemia. This is Raynaud's pentad. I repeat, pain, fever, jaundice plus hypotension and mental confusion. These are called as Raynaud's pentad. क्या बोलते हैं बेटा? Raynaud's pentad. Okay. These, if the patient is going into hypotension, patient is having that mental confusion, you all know nicely, beta. These are the signs that patient is going into shock-like situation, septicemic shock, right? So pain, fever, jaundice, hypotension, mental confusion. This is Raynaud's pentad. Okay, चलिए एक बार फिर से करेंगे बेटा. What is Charcot's? Charcot's. What is Raynaud's? Raynaud's. Charcot's. 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 Raynaud's. बहुत बढ़िया. Perfect. Wonderful. So I hope you have got this nicely inside, that why in cholangitis we get this Charcot's triad, why we get this Raynaud's pentad. Here, please remember beta, the reason of cholangitis may be any. In pediatric surgery, we are discussing choledochal cyst. In adult surgery, when we'll be talking about the stone inside the CBD, if that is causing a complete traffic jam, then also we'll see this cholangitis. In elderly, when we'll be talking about cholangiocarcinoma, and if that is causing a complete traffic jam, patient can have this cholangitis. And whenever there will be cholangitis, whether a pediatric, adult or elderly, the patient will have the Charcot's triad and Raynaud's pentad. I hope this is absolutely clear in your mind, right? Okay. Right, beta. So, in case of emergency, sometimes what we can see, we can find Charcot's triad. This is pain, fever, jaundice. When this pain, fever and jaundice is associated with septicemia, like hypotension and mental confusion, then we call it as Raynaud's pentad. Pain, fever, jaundice, hypotension and mental confusion. This is called as Raynaud's pentad. Now tell me one thing, beta. You are the boss. You are the doctor, right? You are sitting in the emergency, and suppose a patient comes to you with high-grade fever, chills and rigors, severe pain in the right hypochondrium, jaundice, blood pressure is down, he is having altered sensorium. That means the patient is in a state of shock. What will be your first aim? What do you think? Very good. You can understand that this patient is actually losing his life because he's already into shock. So first aim as a doctor would be to save the life. And to save the life, what we are supposed to do, we'll start that basic resuscitation, pumping in IV fluids. Since there is high-grade fever with chills and rigors, you would be giving aggressive antibiotics to control that bacterial party. But you know that if the septic load is too high, the antibiotic injection which you are giving, that may not be sufficient to control such a huge bacterial load. And if that is not sufficient and the bacterial load does not go down, the patient will die. So you have to reduce the septic load from this patient. You know the foci of septic load is bile duct. you have to remove the bacterial party from bile duct. And you know, beta, a very simple procedure what you can do to remove this party from bile duct. You can pass the endoscope from the mouth, take it into the duodenum. Through the side channel of the endoscope, you pass a stent into the duodenum and take this stent into the bile duct. Something like this. See, beta, what we are trying to do here, we know that there is a party going on. There's a party going on into the bile duct. Right. There's a party going on into the bile duct. And we have to remove this party. We have to remove this bacterial load. What we are doing is, we have passed the endoscope through the mouth, esophagus, stomach. This is going into the duodenum. And now, from here, we would be passing a stent type of thing through the side channel of the endoscope. Let me pass a stent through this endoscope. Now let me take the stent through this into the common bile duct. If I am able to take the stent into this common bile duct, this stent what you are seeing, beta, this, just imagine that this is a refill of the ball pen. The ball pen which you are holding now, beta, if you look at the refill of that ball pen, that refill has got a lumen. So just imagine that you have put the refill of this pen where one end is in the party area and the other end is in the duodenum area, right? If suppose you take that refill and create multiple holes here and there in the refill, right? So just imagine that you have created multiple holes in the stent. And now what will happen? Whatever E. coli are partying in this area, these E. coli will come into the refill. And through this refill, these E. coli will come into the duodenum. And once the E. coli comes into the duodenum, they will pass out in stool quickly, right? So that is how we can remove the septic load, by putting a stent into the CBD. This is called as endobiliary stenting. This is called as endobiliary stenting. I'll just remove myself, or I'll take myself on one side. Yeah. Now can you appreciate, beta? Can you see how we have put a stent into the CBD, and that is how the E. coli party can be drained out from the CBD, and you will be able to save the life of the patient. I repeat once again, beta, please listen to me carefully. 17th of December, examiner may give you any situation where there might be obstruction in the common bile duct, because of which there might be proximal dilatation, stasis, infection, party in the CBD, acute inflammation of CBD, cholangitis, Charcot's triad, Raynaud's pentad. Patient is going into septicemia, patient is going to die. First thing what you have to do is save the life. You will do the basic resuscitation, you will give aggressive IV antibiotics, but at the same time, to save the life of this patient, you have to remove the septic load from the CBD. And to remove the septic load from the CBD, the best thing is put a stent into the CBD, which we call as endobiliary stenting or ERCP and stenting. I hope you have got this concept. You will remember this, right? The reason of this traffic jam can be either pediatric surgery, adult surgery or elderly surgery. कारण कुछ भी हो सकता है, right? Fine. So here, beta, what we are doing is we are giving the basic resuscitation, IV fluid, IV antibiotics. We can do a quick LFT and ultrasound, but to remove the septic load from the CBD, we know that we are doing endobiliary stenting. Endobiliary stenting, which we call as ERCP and stenting. ERCP and stenting. These are the various complications which we can see with choledochal cyst beta. Cholangitis is something which we just saw. We also know the concept whenever there is a stasis, whenever there is obstruction, proximal dilatation, stasis, infection, and stone formation in biliary and urinary channels. If the stone forms in the bile ducts, we call it as choledocholithiasis. Here I would like to specify better. Chole means bile, doco means duct, litho means stone, and osis means disease. So choledocholithiasis means stones in bile duct, while beta cholelithiasis, if the examiner is simply writing cholelithiasis, then he is actually referring to stones in the gallbladder. Stones in the gallbladder, right? Sometimes, as we have seen beta, cancer can develop in these choledochal cysts, that is called as cholangiocarcinoma. So important complications: cholangitis, choledocholithiasis, and cholangiocarcinoma. These are important complications of choledochal cyst. Herein I would like to mention beta, if cholangiocarcinoma occurs, then most commonly we see this cholangiocarcinoma in this area. And this is the junction of right and left hepatic duct. We call it as confluence or hilum. So we also call it as hilar cholangiocarcinoma, and the other name for this is Klatskin's tumor. Klatskin's tumor. Klatskin's tumor. Klatskin's tumor. Cholangiocarcinoma, that is cancer in the bile duct. This is most commonly seen This is actually a hilar cholangiocarcinoma. Most common site is the confluence of right and left hepatic ducts. And we also call it as Klatskin's tumor. Klatskin's tumor. So this is all the description related to cholangiocarcinoma. This description is for cholangiocarcinoma. Klatskin tumor is this hilar cholangiocarcinoma. Right, beta. So I hope we have understood this biliary channel choledochal cyst nicely. What we'll do, beta, I'll take a very, very short break. There's someone waiting outside, so I'll just take a break of 10 minutes here. And we'll be back at 11 a.m. Just give me 10 minutes. A common query was that how can we differentiate duodenal atresia and annular pancreas if the presentation is same? We can differentiate that on a CECT. Right, beta. So now let's move a little further and let's try to see another pathology what we can see in right hypochondrium, and that is intussusception. Now intussusception, beta, it is something which is riding off one part of intestine into the adjacent part. Like here, have a close look at this image, beta, because the same image has been asked as an image-based MCQ in your exam. You can see there is invagination of this part of the intestine into the adjacent part. This is the terminal ileum and this is the cecum, and we can make out, because of this small tubular structure what you're seeing, this is the appendix, beta. And you know appendix is present at the base of the cecum. So that means this has to be cecal area, and this is the terminal ileum. So this is ileum going into the cecum, or you can say ileum going into the colon. So we can call it as ileocolic intussusception, right? Fine. Now, why these intussusceptions occur? Why we are reading this whole intussusception here in the right upper abdomen? Just imagine, beta, that if suppose some part of the intestine becomes heavy due to any reason, अगर intestine का कोई part भारी हो जाता है, कारण कुछ भी हो. Now when the peristalsis is coming, the peristalsis is trying to force that heavy part of the intestine to ride into the adjacent intestine. And if one part of the intestine goes into the adjacent intestine, that is what we call as intussusception. Right, beta? This intussusception is most often seen at around 5 to 10 months of age. That means during infancy, chota sa baby. Why? Why it is seen at around 6 months of age? Because till 6 months, we know we give exclusive mother's feed. पहले 6 महीने तक बच्चे को सिर्फ माँ का दूध दिया जाता है. At around 6 months, we start weaning. That means we start giving some top feed. ऊपर का कुछ दूध या खाना देना शुरू करते हैं 6 महीने पे. Now, whenever this top feed is given to the baby, there is a possibility that intestine of the baby may develop some infections. And if we look at the small intestine, that means in the ileum beta, in the terminal part of ileum, we all have got lymphoid follicles in the wall of the terminal ileum. हमारी जो आइलियम का सबसे आखिरी हिस्सा है ना, उसकी जो दीवार है, भगवान ने उस दीवार में लिम्फॉइड फॉलिकल्स दिए हैं, which we call as Pierce patches. क्या बोलते हैं बेटा? Pierce patches. Now, whenever there is any infection in the intestine, these lymphoid follicles, they will swell up. Pierce patches will hypertrophy. And because of hypertrophy of the Pierce patches, the terminal part of the intestine will become heavy. And if this is the terminal ileum, if this becomes heavy, now peristalsis, which is coming from above downwards, right? This will force the heavy part of the intestine to ride into the adjacent part, that is into the cecum, and that is what is intussusception. However, there can be other causes also for intussusception, like sometimes there is a congenital diverticula in the intestine, which we call as Meckel's diverticula. If intestine is having that Meckel's diverticula, then definitely that part of the intestine will become heavy, and peristalsis will force that heavy part of the intestine to ride into the adjacent part. Intussusception can also be seen in adults, and usually in adults or elderly people, we can find polyps inside the colon. If there are polyps present inside the colon, then that part of the colon will become heavy, and peristalsis can force that part of the colon to go into the adjacent part of the colon and result in a colocolic intussusception, right? But overall, the commonest intussusception is a ileocolic intussusception, which is seen at around 6 months of age, where the terminal ileum goes into the cecum. Now, when the peristalsis is coming here, just imagine beta, you take the food from the mouth and the waste comes out from the anus. That means the direction of peristalsis will be in this direction. That is why the story is moving down. Okay? Just imagine that terminal ileum has gone into the cecum, and the peristalsis is forcing the terminal ileum into the cecum, and this peristalsis is pushing the terminal ileum in the cecum, and many times this ileocecal area is actually pushed up into the right hypochondrium, and when the baby is present to us, they present as a sausage mass or a sausage lump in the right hypochondrium. That is why we are discussing this intussusception in the right hypochondrial pathologies, because as a doctor February 23, you might come across a 6-month-old baby with a sausage lump in the right hypochondrium. Sometimes this sausage lump can even move in the midline and may go onto the left side, and you may find a sausage lump here in the periumbilical region also. The concavity of the lump is always directed towards the umbilicus. Concavity of the lump is directed towards the umbilicus. Because the terminal ileum has gone into the cecum, it will cause some injury which can lead to bleeding, and this blood may come in the colon, and then blood will be getting mixed with mucus during the journey in the colon, and baby can pass blood and mucus in stool. Blood and mucus in stool is something what we call as red currant jelly. Red currant jelly stool. Something like this. This is what the baby would be passing. Blood and mucus in stool. That is a red currant jelly stool. Right? Something like this. Right? Like the jam. Apart from this, since the ileocecal region has moved up, that means the cecum is not present in the right iliac fossa. When we are examining these small babies, since ileocecal region is not present here, we find an emptiness in the right iliac fossa. and this empty right iliac fossa is called as sign of dance. जब हम इस छोटे बच्चे को एग्जामिन कर रहे होते हैं तो हमें ऐसा लगता है राइट आइलियक फोसा में कि इस इलाके में पहले कोई रहा करता था, अब अपना घर छोड़ के चला गया है। एक अजीब सा खालीपन महसूस होता है राइट आइलियक फोसा में, जिसको हम साइन ऑफ डांस बोलते हैं, राइट? ओके, अपार्ट फ्रॉम दिस बेटा, if you are doing a per rectal examination in these babies, that is a digital rectal examination, per rectal examination, if you put your finger into the rectum and then you take the finger out, your finger will be stained with blood. Obviously gloved finger, so there will be staining of blood on the glove of the finger. These can be the findings in intussusception. If suppose the baby is presenting with a sausage lump, first investigation, jaldi se bataiye beta, what will be the first investigation if there is a lump in the abdomen? Very good. It will be ultrasound. Now, when you do an ultrasound beta, you can find something like this. Now here, ultrasound is a poor investigation for intestines, that we know, because ultrasound waves, acoustic waves, cannot travel easily through the air. And in your intestine, you have got air. But sometimes we can see, because of edema fluid, fluid is a very good window for acoustic waves. So wherever there is fluid, we can see the structures nicely. अल्ट्रासाउंड करने से पहले हमें बोलते हैं ना बेटा, खूब सारा पानी पीना चाहिए. Before doing the ultrasound, the radiologist tells the patient that we have to drink plenty of fluids, right? So now, fluid is a good window. If there is some edema in this area, we can see this intussusception on ultrasound. Herein, this what you are seeing is a inner tube, and this what you are seeing beta, this is the outer tube. This looks like a donut, right? There is a inner tube and there is a outer tube, right? If suppose we do X-ray in these babies, we can find something like this. Now, this is a case where the sausage lump has moved on the left side, and this is looking somewhat like this, and this border looks like a crescent. Now, crescent we also discussed somewhere in subdural hematoma, where it was convexo-concave. So, subdural hematoma was concave, na beta, hyperdense on CT scan. So, this is a crescent sign, which we can also call as meniscus sign. Sometimes when we are doing barium enema, now in barium enema, we can find something like this. Barium enema is when we are pushing the contrast from below, from the anus, right? Barium enema is a contrast study wherein we are pushing the contrast from the anus. The contrast is going into the colon, and we can see the colon nicely. Up to the cecum, the contrast can go easily, but the contrast usually will not be able to go into the ileum, because at the ileocecal junction, God has given a valve, ileocecal valve, and obviously the direction of valve will be such that it will be allowing things to move from small intestine to large intestine, but not from large intestine to small intestine. That is why when we are doing a barium enema that is pushing the contrast from the anus, you can see the entire colon nicely up to the cecum, but you will not be able to see the small intestine, right? Now, in intussusception, when the contrast is going here like this, then since the ileocecal region has moved up, you can see that the contrast is getting holded up in the cecum. The contrast is not going into the ileum, right? So this type of sign, this is called as a coiled, this is called as a claw sign. क्या बोलते हैं बेटा इसको? Claw sign बोलते हैं. और अच्छे से ध्यान से देखो बेटा इसको. Can you appreciate this claw here? किस तरह से cecum has actually holded the small intestine. That is why it appears like a claw, and this has been asked as an image-based question in our exam. इस फोटो को ध्यान से देखिए बेटा और दिल में बसा लीजिए. This is an important image-based question. What you are seeing here, this is a claw sign on barium enema seen in intussusception, right? Sometimes what happens when we are giving this barium enema, the contrast, if suppose the ileum is tightly fitted, if the ileum is tightly fitted into the colon, right, then the contrast will be holded in the cecum only, and you will be able to see only up to the cecum. You will not see anything in the intestine. But if suppose there is some gap between the intestine and the cecum, for example, there is some gap. Can you see the gap all around the ileum? There's a gap between the ileum and the cecum. Now the contrast which is coming in the cecum, that will create rings around the intestine. And this looks like a coiled spring, just like the spring in a ball pen, that khatke wala ball pen, right? So there is a spring in that ball pen. So when the ileum is not tightly fitted here, there is a gap. Then in this gap, the contrast will be flowing around the intestine, and this will look like a coiled spring sign. So in intussusception, if the ileum is tightly fitted and there is no gap, the contrast will be holded in the cecum only, and that is a claw sign. But if there is some gap between the cecum and the ileum, the contrast will flow around the ileum and will form rings, and that is what is a coiled spring sign. Best investigation for intestines is a CECT. In the treatment, what we want to achieve, we want that whatever ileum has gone inside, that should come out. And for removing this ileum from the cecum, a simple thing what we can do is, we can push something from below with force, like air. If you push air with some force, the air will be going here with force, and the force of air will force the ileum to move out, and the ileum comes out, and that is how the intussusception can be reduced. You can use air, you can use saline, you can even use this contrast or barium with force, and that will help in reducing the intussusception. So the treatment of choice for this intussusception is a air enema. Now herein you are seeing, beta, you have pushed the contrast from here. The contrast is going into the cecum, and because of the pressure, the ileum is going to come out. What you are seeing in this picture, the contrast has been put here, and now because of the pressure, the ileum has reduced. That is how we can reduce these intussusceptions, right? I hope you can see this nicely. Just have a look and compare. In the first picture, the ileum is not reduced. In the second picture, the ileum is reduced. This is the air enema for reduction of intussusception, right? Sometimes, if suppose this air enema, saline or barium does not help, then we have to do operative reduction of intussusception. Then we have to open this area and have to manually reduce the intussusception. In this, what we can do is, we can hold the inner tube and the assistant can hold the outer tube, and then we can try to pull the inner tube from the outer tube. But if we try to pull, this is a edematous friable area, this will cause injury. So it is better that no assistance should be used. You are the surgeon, you hold the outer tube and you gently milk the inner tube out from the outer tube. This gentle milking of inner tube from the outer tube can reduce the intussusception. Sometimes, if suppose during surgery you find that this area has become strangulated or gangrenous, अगर मान लीजिए ये area सड़ा हुआ मिलता है, if this part is found to be gangrenous, we know the treatment for gangrene is amputation. That means here we have to remove this segment of the intestine, इसको उड़ा दीजिए, and the segment which is normal, just join the normal segments. That means resection of the gangrenous segment and end-to-end anastomosis of the remaining segment, right? So that is how we can treat these intussusceptions. Right, beta. So intussusception is simply invagination or telescoping of one part of the intestine into the adjacent part. If we try to see, suppose this tube, what we are seeing here, this is the inner tube, and this inner tube has gone into the outer tube, something like this. This part, that is the point where the inner tube is entering into the outer tube, is called as the neck of intussusception. This part, suppose this small intestine is extending up to this part. Now this point will be called as the apex of intussusception. This terminal point will be called as the apex of intussusception. We can also divide this intussusception into inner tube, middle tube, and outer tube. This what we are seeing, this is the inner tube. This what we are seeing where both inner and outer are present, this is the middle tube, and this one would be the outer tube. The inner tube is also called as entering tube or intussusceptum. क्या बोलते हैं बेटा? Inner tube, entering tube, intussusceptum. Outer tube is also called as the receiving tube or intussuscipiens. Intussuscipiens. Now, most common intussusception what we find, this is ileocolic intussusception. Most common is ileocolic intussusception. Most commonly, it presents at around 6 months of age. However, the range generally it is 5 to 10 months. And most common cause of intussusception is hypertrophy of Pierce patches. Hypertrophy of Pierce patches. Most common ileocolic, most common at 6 months, 5 to 10 months of age, and most common cause hypertrophy of Pierce patches. Most common in adults, it is colocolic, and this is due to polyps in the colon. Clinically, the baby presents with a sausage lump in the right hypochondrium. Like here what you're seeing, beta. This I hope you can appreciate. This is a sausage lump. Something like this. And the concavity of this lump, this is the concavity. This is directed towards the umbilicus. Whether the lump is seen in this area, then also the concavity of this lump will be directed towards the umbilicus. Right. Apart from this, these babies can present with blood and mucus and stool, which we call as red currant jelly stool. Red currant jelly stool. Empty right iliac fossa is called as sign of dance or dance sign. Dance sign is seen in intussusception. Ileocecal region is dancing in the abdomen. On digital rectal examination, DRE beta, this DRE is digital rectal examination, or you can say parrectal examination. The examiner's finger is stained with blood. The baby may present with excessive cry and discomfort. First investigation, what we do in intussusception, because of sausage lump, we do a ultrasound of the abdomen. And on ultrasound, we find a donut sign. Donut sign. If we do a X-ray, then on X-ray we find a crescent sign, which we can also call as meniscus sign. On barium enema, we find a claw sign. Now this image has been asked number of times. This language has been asked number of times. We can also find a coiled spring sign in intussusception on barium enema. Best investigation, however, should be CECT of the abdomen. Best investigation should be CECT of the abdomen. For intestines, overall, the best investigation is CECT. These are the images of red currant jelly stools and claw sign in intussusception. This is a hot image-based question, beta. Please be careful. This is a claw sign or barium enema in intussusception. Treatment of choice is hydrostatic reduction, where we prefer using air enema. However, we can use saline and barium also, but minimum injury to the intestine is caused by air if we compare with saline and barium. So we prefer using air enema, and that reduces the intussusception. This is the image of how the intussusception can be reduced by air enema. If by chance this hydrostatic reduction fails, then we have to do operative reduction. In operative reduction, the precaution which we have to take, we should never pull. We should always push. We never pull, but we always push. And here we can make a note that gentle milking of outer tube to reduce the inner tube. Gentle milking of outer tube to reduce the inner tube. That is what we are doing in operative reduction. If suppose we find that this area is gangrenous, then if we find that this area is gangrenous, then we do a resection and end-to-end anastomosis. We just chop the gangrenous part and do a end-to-end anastomosis of the normal part. So that is how we manage the intussusception, right? So beta, in the right hypochondrium, we talked about biliary atresia, we talked about choledochal cyst, and we have talked about intussusception. Let's just take a quick recap of these three. Biliary atresia was absence of biliary channels. The exact cause was not known, but this was due to inflammatory fibrosis of biliary channels starting in the first week of life. There can be three types of biliary atresias. Type 1 absence of CBD, type 2 absence of CST, type 3 absence of right-left hepatic duct. Most common is type 3. Now, whenever the biliary channels are damaged or obstructed, the patient will have jaundice, steatorrhea, malabsorption, and here hepatomegaly. Usually this condition presents in the first week of life. Any patient who presents with jaundice, the first investigation will be LFT. Any patient who presents with abdominal mass, the first investigation will be ultrasound. Investigation of choice for biliary atresia is a HIDA scan, and the treatment for type 1 is a Roux-en-Y hepaticojejunostomy, while for type 2 and type 3, we do a Kasai operation, that is hepaticoportoenterostomy, but eventually we have to do a liver transplant. Right. Then we talked about choledochal cyst. These are cystic dilatations of biliary channels. Exact cause is not known, but probably due to anomalous pancreaticobiliary duct junction. Rodani classified these choledochal cysts into 5 types. Type 1, 2, 3 involve the CBD. Type 4 and 5 involve the hepatic ducts. Most common out of these is type 1, which is a diffuse dilatation of the CBD. 2 is dilatation of CBD above the pancreas. 3, dilatation of CBD within the pancreas, which we call as choledococele. 4a, multiple intra and extrahepatic duct dilatations. 4b, multiple only extrahepatic duct dilatation. 5, multiple only intrahepatic duct dilatation. 5 is also called as Caroli's disease, where central dot sign in Caroli's corresponds to the portal vein. The patient's presentation can be either in OPD or in emergency. In OPD, the babies can present with painless intermittent jaundice in infancy, or maybe mass in the right hypochondrium. If jaundice, then LFT first. If mass, then ultrasound first. LFT ultrasound are complementary to each other, and we will come to know about this choledochal cyst on ultrasound, but the best investigation or investigation of choice can be ERCP. Since these choledochal cysts has the risk of complications like cancer, so we have to excise these cysts, and once we excise the cyst, we take the help of innocent guy and we do a hepaticojejunostomy. Sometimes these patients can present in emergency when the party is going on in the bile duct, that is cholangitis, can present with Charcot striate, pain, fever, jaundice, which can complicate into septicemia and present with hypotension and mental confusion along with pain, fever, jaundice, that is Raynaud's pentad. In this, our priority is to save the life. We do the basic resuscitation, give IV fluids, IV antibiotics, do a quick LFT ultrasound, and do a endobiliary stenting or ERCP and stenting. That will reduce the septic load and save the life of this patient. Once the life is saved, then after a few days when the infection settles down, we can do a cyst excision and hepaticojejunostomy. These choledochal cysts can present with complications like cholangitis. Stones can form inside the biliary channels. Choledocholithiasis, cancer can occur in the biliary channels. Cholangiocarcinoma, commonly cholangiocarcinoma is seen at the hilum or the confluence of right and left hepatic ducts. This is called as hilar cholangiocarcinoma or Klatskin's tumor. In the right hypochondrium, we also talked about intussusception, which is invagination of some part of the intestine into the adjacent part. Most commonly, the ileocolic intussusception, presenting most often at 6 months, 5 to 10 months of age due to hypertrophy of Pierce patches. In adults, it is colocolic due to polyps in the colon. Generally, these babies present with a sausage lump in the right hypochondrium with the concavity directed towards the umbilicus. Babies may pass blood and mucus in stool, that is red currant jelly stool. Babies when we examine these babies, there may be empty right eyelid fossa, which is called a sign of dance. When we do a digital rectal examination, the examiner's finger is stained with blood. If the baby is presenting with mass in the right hypochondrium, we do an ultrasound and we can find a donut sign. If we are taking an X-ray, we can find a meniscus crescent sign, barium enema, claw sign, or coiled spring sign can be seen. Best investigation would be CCT, and the treatment should be reduction of intussusception, which we can do by using air enemas. We can even use saline and barium enemas for this. If enema hydrostatic reduction fails, then we do operative reduction, where we never pull, always push, gentle milking of the outer tube in order to reduce the inner tube. If the involved segment looks to be gangrenous, we cannot keep the gangrene inside. We have to chop the gangrenous part off, that is resection of the gangrenous segment, and then join the remaining parts of the intestine end-to-end anastomosis. So this is what we talked in the right hypochondrium. Now we move to the lumbar region, and let's take a look at some small stories related to the kidneys. There are 4 pathologies what we are discussing here: absent kidney, ectopic kidney, polycystic kidney, and horseshoe kidney. Right. So these 4 pathologies, very simple: absent kidney, ectopic kidney, polycystic kidney, and the horseshoe kidney. These are 4 pathologies we are discussing here. Absent kidney, we can understand when the kidney is absent. How many kidneys are we having, beta? 2 kidneys. 1 in 1,000 people may be having only 1 kidney, and they can carry on their normal life. Why this 1 kidney can be absent? Maybe due to renal agenesis. भगवान गुस्सा थे, भगवान ने 2 नहीं 1 ही किडनी दी है. This is due to renal agenesis. But generally these patients will not be having any problem. There will be compensatory hypertrophy of the other kidney, and the patient will be able to carry out the normal life. Ectopic kidney, that means the kidney is not present at its normal location but is present somewhere else. For this, if we try to understand what actually happens during intrauterine life, suppose if we take a look, that kidneys, they start developing in the pelvic area in the retroperitoneum during intrauterine life. जब बच्चा माँ के पेट में होता है, kidneys, they start developing in the pelvic area, and gradually during intrauterine life, these kidneys are ascending upwards, and they finally reach to their lumbar location, right? Sometimes, if suppose 1 kidney fails to ascend upwards, 1 kidney suppose has ascended, but the other kidney fails to ascend upwards, now what can happen? This kidney will be arrested in the pelvis. That means this is not in the normal location, and this we call as ectopic kidney. You would be surprised that 1 out of 400 people are having ectopic kidneys. Again, no problems, and the patient can carry out the normal life. Most commonly, they are seen on the left side, and most commonly they are located in the pelvis in the retroperitoneum. Ectopic kidneys, most often they are found in the left side in the pelvis and retroperitoneum, and this is because kidney fail to ascend. Kidney ऊपर नहीं चढ़ पाती है, fail to ascend. Polycystic kidney. If there are multiple cysts inside the kidney, for example, if suppose this is the normal kidney, something like this, if this is something which is normal, now sometimes what happens, we can find cysts in these kidneys. And because of the cyst in these kidneys, the kidneys will definitely enlarge. And the story can be something like this. Because of the cyst, the kidneys can enlarge. And what we have commonly observed, that we find multiple cysts in both the kidneys. And that is what is a polycystic kidney disease. This is basically two types. One is congenital, another is infantile. Congenital, though it is present right from the birth, but it usually manifests later in life after 30 years of age, and we also call this as adult polycystic kidney disease. The other type, infantile, that presents in infancy, that is much rare and is associated with very high mortality. So we have got two varieties of polycystic kidney. One is congenital, which is also called as adult. Another is infantile. The congenital or adult polycystic kidney disease is autosomal dominant, while infantile is autosomal recessive. Okay. Since infantile variety is associated with high mortality, we usually do not come across these patients, and it is extremely rare also. So what you are going to expect in February 23, you may come across patients of adult polycystic kidney disease, which is also called as congenital. These are bilateral. They can be associated with cysts in other organs of the body, like most commonly they are seen in the liver. We just talked about Caroli's disease in the liver. So same way, this polycystic kidney disease can be associated with multiple cysts developing inside the liver. Sometimes these cysts can also be found in the spleen, pancreas, ovaries. Sometimes these polycystic kidney disease babies or patients, they have Berry aneurysm. Now, Berry aneurysm is an aneurysm of circle of Willis. Sometimes we find mitral valve prolapse in these polycystic kidney disease babies. All these are genetic associations. Majority of the times, these patients have no problems up to 30 years of age. As the cysts are enlarging slowly and slowly, after 30 years of age, there might be some problems. As we have seen that the kidneys can enlarge, so we can find swelling. And since these kidneys are in the lumbar region, so we can find a swelling in the lumbar region. Because of stretching of the kidney capsule, these babies or these patients after 30 years of age, they might present with pain. So swelling and pain in the lumbar region, both sides. Apart from this, we find hematuria in these cases. Now, we know that inside the kidney there are nephrons. So, if suppose I say that here there are nephrons, now many times bleeding can occur and this blood can go into the nephrons. If the blood is coming into the nephrons, then you know that these nephrons are actually connected with the calyceal system. There are minor calyces, then there are major calyces, and then there is renal pelvis, and then comes the ureter. So if there is bleeding taking place here, this blood can go into these nephrons, and that is how the blood may come out in urine. Hematuria. Hypertension can occur, that is genetic, in 75% of patients, and uremia can occur. Now, why uremia? Here we should know that this is a bilateral condition. If we actually try to see what we find in these polycystic kidney disease inside the kidney, Like these are the examples. This is how the multiple cyst in the kidney can look like, right? Now, what is happening inside? If you take a look at the inside story, these are the cysts what you are seeing. You can just imagine that what would have happened to the renal parenchyma or the nephrons because of these cysts. The parenchyma would have been compressed and damaged. That means these nephrons would not be able to work. Now, if both the kidneys are involved, both kidney nephrons are not able to work, then how will filtration occur? We all know that the various end products of cellular metabolism, the waste products like urea and creatinine, they are continuously being filtered by our kidneys and they are going out in urine. But if the kidneys, if the nephrons are not working, they will not be going out in urine. They'll keep on rising in blood, and that is what we call as uremia. Now, if these type of patients come to us in practice with swelling in the lumbar region, the first investigation we prefer would be a ultrasound. Ultrasound of the abdomen can show us multiple cysts inside the kidney. And we can make a diagnosis that yes, both the kidneys are getting involved. This what we are seeing is a CECT picture. CECT is the best investigation or investigation of choice. Here you can see, beta, this is the outline what you're seeing. This can be an image-based question also. Okay, so this is the outline what you're seeing. Here also, if you focus, you can see the outline of the kidney, and then you are able to see multiple black shadows all over the place in both the kidneys. That is how a polycystic kidney can look like. What actually has happened to the pelvic ileal system? Normally, if we try to draw the pelvic ileal system, if suppose, just a moment. Right, beta. So if we just take a look at the outline here, okay. Normally, if we take a look at how these nephrons are actually pouring their urine, suppose there are millions of nephrons here, they are connected to the calyceal system. These are the minor calyces. Then these are the major calyces. This is the renal pelvis, and here lies the ureter. So normally when we are doing a contrast study, any contrast study, whether we are giving the contrast in the peripheral vein, like intravenous pyelography or intravenous urography, or we are doing CT scan with contrast, normally we should see this pelvic calyceal system something like this. The contrast should be filling from the nephrons. The contrast would be going into the minor calyces. The contrast will be going through the minor calyces like this, and then it is going to fill these minor calyces. The contrast would be traveling down like this. The contrast would be traveling like this in the major calyces, and then the contrast would be coming into the renal pelvis area. And then this contrast from the renal pelvis would be moving down like this into the ureters. So this should be the normal finding, okay? But what will happen if suppose there are multiple cysts developing inside the kidney? Now these multiple cysts, they are going to put pressure on these calyces also. And because of this pressure, these calyces are going to get compressed. And now when you are doing the contrast study, what actually you will find is, you will find these contrasts to be moving somewhat like this. There will be thinning of the calyces. There will be thinning of the calyces somewhat like this. And we may be seeing something like this. And then we would be seeing the renal pelvic area. And then we would be seeing the ureter. Something like this. Now this thinning of the calyces, what you're seeing, this looks like the spider leg. जैसे spider legs होते हैं ना बेटा, वो जो मकड़ी होती है, वो जो जाला बनाती है. If you look at the spider legs, they're very thin, spread out. So if we are talking about polycystic kidney disease, and if we are doing a contrast study, then we find these splaying of the minor calyces, the thinning of the minor calyces, right? This is called as a spider leg appearance. If you just try to correlate with this, can you see how the minor calyces have thinned out? This is the classical spider leg appearance, which is seen in polycystic kidney disease because of compression of the calyces, right? Before we move, I would like to tell you about few contrast studies. As we have been talking about these contrast studies at a lot of places, like in intussusception we talked about barium enema, and now we are talking about contrast in the CT scan. We talked about the intravenous pyelography. So what I'll do is I'll first explain all these different contrast studies to have a clear idea inside. Okay. Right. Now here in beta, look at me on the screen. Let us try to find out the different contrast studies in GIT and urinary tract. When we say GIT, we commonly are using barium as the contrast, right? If we have to study the esophagus, then we call barium swallow. If we have to study the stomach, barium meal. If we have to study the duodenum, jejunum, ileum, then barium will follow through. And if we have to study the colon, then barium enema, right? What are these different terms? Why we are calling these swallow, meal follow through, and enemas? For example, if you have to study the esophagus with a contrast, you will be giving the contrast through the mouth. This contrast is actually a liquid medicine which is mixed in water or maybe normal saline. And suppose this much is the liquid contrast medicine, you can take a water bottle of 2 liters and you can just mix this contrast in that water. So now this liquid medicine is mixed with the water. And then you ask the patient to swallow this contrast. Patient keeps on swallowing this contrast slowly and slowly, maybe for half an hour. And then you take this patient in the X-ray room and take the X-ray. And you can see the contrast nicely in this GI tract. If we have to read the esophagus, there is a small challenge. Suppose patient has come to your clinic and you have got the X-ray machine in your clinic. You give the contrast to the patient in your chamber. Suppose the patient swallows the contrast right in front of you in the OPD. Now, after some time, maybe after 5 minutes, 10 minutes, you tell the patient, okay, come in the X-ray room, let us take the X-ray. Now, when you are taking the X-ray, patient swallowed the contrast 5-10 minutes back. So when the patient has already swallowed the contrast is not lying in the esophagus. The contrast would be lying inside the stomach. So when you are taking the X-ray, you are not seeing the esophagus, you are actually seeing the stomach. That means to study the esophagus, this is not the right approach. What we should ideally do, we should give this contrast to the patient, ask the patient to take this contrast in the X-ray room. Inside the X-ray room, we ask the patient to swallow the contrast. While the patient is swallowing the contrast, you are taking the pictures, and that will show you the esophagus. That is what we call as barium swallow. We know that food remains inside the stomach for 2 to 3 to 4 hours. So whatever contrast you are giving to this patient, this contrast may remain inside the stomach for maybe 1 hour, 2 hours, right? That means if you are able to take the pictures within 1 hour of the patient swallowing the contrast, you will be able to see the stomach nicely on this contrast. And this is what we call as barium meal. क्या बोलते बेटा इसको? Barium meal. If you have to study the duodenum, jejunum and ileum, nobody knows after how much time this contrast is going to come into the duodenum. Nobody knows after how much time this is going to come into the jejunum. Nobody knows after how much time this is going to come into the ileum. It may take 2 hours, it may take 4 hours, it may take 6 hours, it may take 12 hours. That means we are not sure. So suppose the patient has come to us at 9 o'clock in the morning and patient has swallowed the contrast at 9 o'clock in the morning, then if you have to see the duodenum, jejunum and ileum, you have to keep on taking serial X-rays, because maybe after 4 hours the contrast comes into the duodenum and maybe in 6 hours the contrast comes into the jejunum. So what you can do is you can call the patient maybe after 2 hours, take the X-ray, and you will see, oh, the contrast is still lying inside the stomach. Okay, what you do, you come after 1 hour. Patient comes again after 1 hour, you take another X-ray. And you can find, oh yes, the contrast is moving into the duodenum. If you have to study, suppose the terminal ileal pathology, 600 centimeters, the contrast is definitely going to take a long time to travel, right? So you may call the patient maybe after 2 hours, maybe after 4 hours. If by chance the patient goes to his home and then he comes tomorrow, maybe in the afternoon, and then he tells you that, doctor, see, I have come, please take my x-ray. Then when you take the x-ray, there may not be any contrast inside, because the contrast may be out today morning at his home, right? So, moral of the story, beta, if we have to study the duodenum, jejunum and ileum, we have to keep following the contrast, and that is what we call as barium meal follow through. We are following the contrast, right? If we have to study the colon, we do not wait for this contrast to go into the colon, because this is going to take a long time. If we have got some other easy option, like if we can give the contrast from below with some pressure, the contrast will be coming into the anus, into the rectum, into the sigmoid, into the descending, transverse, ascending, and the cecum, and then you can take the click the pictures immediately. You will be able to see the entire colon. So to study the colon, we don't give the contrast from the mouth, but we give the contrast from the anus, and we can see the large intestines, the colon, by barium enema. Right, beta? So the entire GI tract, if you have to study the esophagus, barium swallow, stomach, barium meal, duodenum, jejunum, ileum, barium meal follow through, colon, barium enema. Can you repeat this with me, beta? Esophagus के लिए क्या करते हैं? What do we do for esophagus? Very good. Stomach, very good. Duodenum, jejunum, ileum, very good. And colon, wonderful, very good. Once again, let's do it, beta. Huh? Esophagus, stomach, duodenum, jejunum, ileum, colon, good. Esophagus, swallow, stomach, meal, duodenum, jejunum, ileum, meal follow through, colon, enema. एक बार फिर से करते हैं. Esophagus, stomach, duodenum, jejunum, ileum, colon, perfect. Once again, esophagus, stomach, duodenum, jejunum, ileum, colon. Once again, esophagus, stomach, duodenum, jejunum, ileum, colon. Perfect, beta. Great. So I hope the GI contrast studies are under your control, right? Now let's go into the urinary tract. In the urinary tract, beta, we know there are kidneys. Kidneys are present here. Then we know there are ureters. These ureters are coming towards anterior side, and then here is the bladder, and then there is the urethra. So kidney, ureter, bladder, urethra. This is the entire urinary tract. We can divide this urinary tract into upper tract, lower tract. Upper tract, kidney, ureter. Lower tract, bladder and urethra. Right? If we have to study the upper urinary tract, what we can do? We can give a contrast into the peripheral vein, intravenous. This will be going through the circulation, and within 11 to 14 seconds, this contrast will reach to the kidneys. And then, if the kidneys are working, the contrast is going to filter through the nephrons. It will be coming into the minor calyces, major calyces, renal pelvis, and ureter. And you can study the kidney and the ureter nicely on intravenous pylography, or we can say intravenous urography. For the upper urinary tract, we have got intravenous pylography or intravenous urography. There may be some rare situations where, suppose I say there is a traffic jam in the renal artery, and the contrast is not able to go into the kidney. If you have given the contrast here, this contrast will be coming to the kidney via the renal artery, right? So if there is a renal artery stenosis, then this contrast is not coming in the kidney. and then you will not be able to see the kidneys, ureters. In these cases, if you still want to see the kidney and ureter, you have an option that under ultrasound guidance, you make a small puncture in the skin here and you pass a catheter or a needle through the skin into the renal pelvis, push the contrast, and then the contrast will be flowing from the renal pelvis towards the ureter. This, by putting a needle into the renal pelvis and then giving the contrast, which move from above downwards, this is called as antegrade pyelography. Antegrade pyelography. However, this is invasive. There is another thing what we can do better. If we can pass a endoscope through the urethra into the bladder, and then through that endoscope we pass a catheter, a long catheter, patla catheter, fine catheter. If we pass that catheter through the endoscope into the ureter, right? Take this catheter for this much distance, just 1 centimeter into the ureter, and then push the contrast in this catheter. The contrast will be going from below upwards, and you will be able to see the ureter and the pelvis. This is called as retrograde pyelography, right? So to study the kidney and the ureter, the best thing is intravenous pyelography or intravenous urography. However, we have the option of antegrade pyelography and a retrograde pyelography. Out of antegrade and retrograde, retrograde is less invasive. So for the upper urinary tract, the different contrast studies what we can do are IVP or IVU, antegrade pyelography and retrograde pyelography, right? Okay. If we have to study the lower urinary tract, urinary bladder, urethra, there is no point in giving the contrast here because there is a much easier access which we have. That is, you can just pass a catheter through the urethra into the bladder, push the contrast into the bladder, take the catheter out, contrast inside the bladder, take the photograph. So simple. Just a catheter in the bladder, contrast in the bladder, remove the catheter, take the photograph, you will see the contrast in the bladder. This is called as cystogram or cystography. Cystogram or cystography. If you have to study the urethra, right? This was a question, image-based question, 4th of June 2022. If you have to study the urethra, a very simple investigation. You can just take a fine catheter, beta, put this fine catheter into the urethra only for this much distance, right? Just put the tip of the catheter in the urethra and then push the contrast. The contrast will be traveling from below upwards in the urethra and you take the photo, right? So the contrast is moving up into the urethra and you can see that on X-ray. This is called as retrograde urethrogram. क्या बोलते बेटा इसको? Retrograde urethrogram or RGU, retrograde urethrogram. That is how we can study the urethra with the contrast studies, right? Apart from the cystogram for bladder and retrograde urethropography for urethra, there is another investigation which is required in two pathologies. That investigation is micturating cystourethrogram. Micturating cystourethrogram. The other name is voiding cystogram. Now, micturating cystourethrogram, micturating means what? Oh, micturating means while passing urine. While passing urine, you are going to take the photograph. That can be required in two situations. One is a posterior urethral valve, another is a vesico-ureteric reflux. Now what is this? Vesico-ureteric reflux. Vesico means bladder. If suppose there is some pathology in the patient wherein the urine which comes into the bladder starts going back into the ureter, that will be called as vesico-ureteric reflux, right? Okay. Another pathology is posterior urethral valve. Posterior urethral valve. Now, if you look at the male urethra, the length of male urethra is approximately 20 centimeters. Male urethra can be divided into posterior urethra and anterior urethra, right? Posterior urethra can be further divided into prostatic urethra and membranous urethra. Anterior urethra can be divided into perineal or bulbar and penile urethra, which we'll be discussing a little later, right? Here, for the understanding, let us just imagine that suppose this is the urinary bladder, okay? This till my mouth, till my face, suppose this is the urinary bladder, right? And here, this is the urethra. Now what is going to happen? Sometimes in posterior urethra, only in case of boys, valves can be present. And the direction of valve is such that they can allow anything to pass from below upwards, but will not allow anything to pass from above downwards. If I am saying that this is the bladder and this is the urethra, what should be the normal direction? The story from the bladder should be coming into the urethra. But if the valves are present, they are not allowing the bladder story to come into the urethra. Okay. But these valves can allow anything to pass from below upwards. If you have to know that whether this patient is having valves or not, and if you are trying to do a retrograde ureterogram, you are giving the contrast from below, the contrast will be going into the urethra, the valves will open up and the contrast will go into the bladder, and you will find that there is no problem in the urethra because these valves can allow anything to pass from below upwards. So if you are giving the contrast from below, the valves open and the contrast goes up into the bladder. No pathology seen. If you have to see whether there is any posterior urethral valve, you want that contrast should move from bladder into the urethra. If valves are present, then these valves will not allow this contrast to move down, and you will see the holding of contrast above the valve, right? That means we want that contrast should move from the bladder into the urethra. How the contrast will move from bladder into the urethra? Bladder से urethra में contrast कैसे आएगा? Right now, beta, all of you are sitting, right? If suppose I say that suppose you put a catheter through your urethra into the bladder, right? And through this catheter, you just push the contrast in your bladder and take the catheter out. If I take the photograph at this point of time, then the contrast will be seen only inside the bladder, right? So contrast is not coming in the urethra. When do you expect that this contrast can come down in the urethra? Only when you are going for micturition. When you are going for urination, at that point of time, the bladder will contract. And at that point of time, the contrast from the bladder will move down in the urethra. And as soon, what we do, we ask the patient to come into the X-ray room after we give the contrast in the bladder. Ask the patient to lie on the X-ray table. Ask the patient to pass urine on the X-ray table. As soon as the patient starts passing urine, the contrast is coming from the bladder in the urethra. You start taking the pictures. This is what we call as micturating. cystourethrogram. And with this investigation, we can come to know about the posterior urethral valves. Also, beta ji, if we have to see vesico-ureteric reflux, that means reflux from bladder into the ureter. Very simple to understand. This reflux will be more prominent at that point of time when the bladder is contracting. So, if you have to contract the bladder, the easiest way is you ask the patient to pass urine. If you have to demonstrate the reflux from bladder into the ureter, you have given the contrast in the bladder from below, remove the catheter, ask the patient to pass urine. Now when the bladder contracts, the contrast from the bladder can go into the ureter if there is vesico-ureteric reflux. So, to study two pathologies, vesico-ureteric reflux and posterior urethral valves, we are doing this micturating cystourethrogram or voiding cystogram. Now what we do, beta, let us revise the urinary contrast studies. If you have to study the upper urinary tract, kidney, ureter, IVP or IVU. If not possible, antegrade, retrograde pyelography. For the lower urinary tract, bladder, cystogram or cystography, urethra, retrograde ureterogram. That's it. Rarely, for two pathologies, we have to do a micturating cystourethrogram or a voiding cystogram. And these pathologies are vesico-ureteric reflux and posterior urethral valve. Right? If we revise all the contrast studies together, beta, GIT and urology. GIT, esophagus, swallow, stomach, meal, duodenum, jejunum, ileum, meal follow through, colon, enema. Urology, upper urinary tract, IVP, IVU, antegrade, retrograde pyelographies, lower urinary tract, bladder, urethra, bladder, cystogram, cystography, urethra, retrograde ureterogram. Two pathologies, vesico-ureteric reflux, posterior urethral valve, we do micturating cystourethrogram or a voiding cystogram. समझ आया बेटा? चलिए, let's move further and let us write about these contrast studies also. Okay. What you can do, beta, you can just write on the blank pages if they are there in the book. I was just trying to search some area where I can mention this. Contrast studies of GIT for esophagus, we use swallow. For stomach, we use meal. For duodenum, jejunum, ileum, we use meal follow through. And for colon, we use enema. So these are the contrast studies for GIT. If we talk about contrast studies of the urinary tract, contrast studies of urinary tract, upper urinary tract, that is kidneys and ureters. We can do IVP or IVU. This is intravenous pylography, or you can say intravenous urography. Other investigations what we can do for upper urinary tract, we can do antegrade pylography, and we can do retrograde pylography. Antegrade or retrograde pylography. If we look at the lower urinary tract, that is bladder and urethra. Bladder and urethra. Then for bladder, we do cystoscopy. gram, or we can also call it as cystography. For urethra, we do retrograde urethrogram, which can be written as RGU. Right, beta? Now, apart from this, for two pathologies, posterior urethral valves and vesico-ureteric reflux, we do MCU. For posterior urethral valves and vesico-ureteric reflux, we do MCU. This is micturating cystourethrogram, or we can say voiding cystogram. For posterior urethral valves and vesico-ureteric reflux, we can do a MCU, that is micturating cystourethrogram or voiding cystogram. So these are the different contrast studies, beta, what we are doing in the GIT and the urinary tract. And I hope you have a clear concept in this. Right. Now let's go back to our discussion that we were trying to understand what happens in polycystic kidney disease, how we are seeing those spider leg appearances. Let us go back to this picture. Now here in this particular case, beta, this is a CECT what we are doing, and when we are giving the contrast and the contrast is coming through the nephrons, there is thinning of the calyces. This is just like the spider legs. Also, beta, we can appreciate that because so many nephrons have been injured and now the patient is going into uremia, when the kidneys have failed, then initially we can do some trial by removing the capsule of the kidney so that the pressure on the cyst can be relieved and some nephrons can function. But eventually, beta, both the kidneys, they fail in polycystic kidney disease. And you know, in Caroli's disease, we did a liver transplant. In polycystic kidney disease, we can do a kidney transplant. If both the kidneys are diseased, then we just buy a new kidney from the market, not from the market, but yes, from the relative, and we can put this kidney inside the patient. This transplanted kidney is placed in the iliac fossa. This is not the normal location of the kidney. Normally the kidneys are present in the lumbar region, but here we are putting them in the iliac fossas, right? This type of transplant is called as heterotopic transplant. Whenever the transplanted organ is not placed in its normal anatomical location but placed somewhere else, we call it as heterotopic transplant. Heterotopic transplant, right? Okay. The association of the polycystic kidney disease, where we are having multiple cysts inside the kidney. This can be associated with multiple cysts in other organs, and that is a genetic association, right? That is not this polycystic kidney is going to cause cyst in the other organs, but that is just a genetic association, right? So when we are taking the kidney from the donor, now which kidney should we take from the donor? Should we take it from the right side or from the left side? Now here in beta, if suppose I say that this is a donor, you can see that aorta is situated almost in the midline, but inferior vena cava is situated slightly onto the right of midline. This what you are seeing is the right renal vein, and this you are seeing the left renal vein. Because inferior vena cava is situated slightly onto the right side, that is why right renal vein is short and the left renal vein is long. When we have to take the kidney from the donor, we want a good length of the renal vein, so that when we are doing the anastomosis in the recipient, if we have got a good length of the renal vein, then the results of anastomosis would be better. So many times the MCQ people can ask you, when you are doing a kidney transplant, which kidney we take from the donor? It is the left kidney, because we can get a good length of left renal vein if we are taking the left kidney as compared to the right kidney, right? Okay, so now let's see what all is written in the workbook. Right. Clinically, these polycystic kidney disease patients, they manifest after 30 years of age. There may be swelling and pain. The swelling and pain would be in bilateral lumbar region. Bilateral lumbar region. There may be hematuria, hypertension, and uremia. If the patient presents with swelling, then first investigation is ultrasound. However, investigation of choice would be CECT of the abdomen, what you saw just now. If we are doing a intravenous urography or intravenous pyelography, we see the characteristic appearance, spider leg appearance. Spider leg appearance in polycystic kidney disease. Now this is something which has been asked earlier quite a number of times. Spider leg appearance is seen in polycystic kidney disease. Right. Initially in the treatment, what we can do, we can try doing a deroofing of the cyst, but eventually we have to do a renal transplant. And the transplanted kidney is placed in the iliac fossa. Whenever we are transplanting the organ and putting it in a different anatomical location, we call it as heterotopic transplant. So we are keeping the transplanted organ in a different anatomical location. When we are keeping the transplanted organ in a different anatomical location, then we call it as heterotopic. And liver transplant is generally orthotopic. Orthotopic means in liver transplant, beta, we are putting the transplanted liver in the same anatomical location, that is right hypochondrium. Same anatomical location. Usually, left kidney is preferred from the donor due to long left renal vein. And this is what I have tried to show in this particular diagram as well. that why we take left kidney from the donor. This is about the polycystic kidney. Oh my God, this is already written here. I'm so sorry. I did not notice that. Okay. So contrast studies of the urinary tract, beta, no issues. What we can do is we can just delete this part, because I think the same thing would have been mentioned, I guess. Yeah. So we can just remove this part. Okay. Right. Acha, can you tell me, beta, this MCU or micturating cystourethrogram is done for which pathology? Posterior urethral valve and vesicoureteric reflux. Another pathology, or the last thing in the lumbar region, beta, this is horseshoe kidney, and the incidence of this horseshoe kidney is 1 in 900. This is what actually happens in this. If we take a look at this image, now this what you're seeing here, beta, this is a horseshoe, right? Sometimes we can find the kidneys like this, something like this. Now what happens, beta, during intrauterine life, when the kidneys are ascending upwards, right? So many a times, ideally the kidneys should have been going away from each other. But sometimes when they both look at each other, they find some similarities amongst them. And in this case, when they're ascending upwards, they may try to come close to each other. And sometimes at the level of L3, there is an inferior mesenteric artery, and this may arrest the ascent of the kidneys, so that the lower poles of the two kidneys, they fuse in the midline at the level of L3, L4 vertebra. And this results in the horseshoe kidney. Since both the kidneys are not able to reach to the lumbar region, that means both the kidneys are ectopic in location. Now, in general, beta, normally the patients are not having any problem. Sometimes what happens, if suppose the ureters, what you're seeing here, these ureters are traveling, say, a little more medially. Suppose the ureters are traveling in this area. Then what can happen sometimes? Because just behind the ureters, there is isthmus. There is isthmus behind, right? So this may be a bulky area, and this might put pressure on both the ureters, and it may create some traffic jam type of story in both the ureters. Because of the pressure, there might be a traffic jam or narrowing of the ureters, right? In these cases, you know very well what will happen to the proximal people. The proximal people are going to get dilated somewhat like this, and this will cause enlargement of both the kidneys. The urine will get collected here, the hydronephrosis. There will be swelling in both the kidneys. There might be pain. But remember, this horseshoe kidney is not in the lumbar region. This is in the lower abdomen. So there will be swelling and pain in the lower abdomen. We also know whenever there is a traffic jam situation, proximal dilatation, stasis, party, infections can occur, UTI can occur, stones can form. These can be the complications in horseshoe kidney. How to diagnose this? if the patient comes to you with a swelling in the lower abdomen, suppose a 3-year-old girl child is having swelling in the lower abdomen, then you can do an ultrasound and you will come to know that, oh my God, the kidneys are not in the lumbar region. The kidneys are somewhere in the central part of the abdomen. If you do a CECT beta, this is what you can find on a CECT of the abdomen. Can you see what has happened to the kidneys? This is the classical horseshoe, what you can see in a horseshoe kidney, right? In these cases, what will happen to the pelvic-calyceal system? Since there is a traffic jam in this particular area, there's a traffic jam here, and the proximal pelvic-calyceal system are actually getting dilated. So what we can find is, we can find the minor calyces in this particular shape, then the major calyces, then the other calyces may be somewhat like this, other calyces may be somewhat like this, and this is how you may find these calyces. The same story on the other side also, beta. And this story, what you're seeing, when the contrast is used and the contrast fills up the story somewhat like this, this looks like a bouquet of flowers. Bouquet of flowers, or you can say a flower vase appearance. Flower vase appearance or flower vase uretus. Right? So we can find this flower vase uretus in horseshoe kidney. Right? Okay, in the treatment for this horseshoe kidney, if the patient is having UTI, then we give antibiotics. If the patient is having stone, we remove the stone. Ideally, what we should have done is, we should have divided the isthmus of the kidney and we should have separated the two kidneys. But unfortunately, beta, we know that 3 solid organs in our abdomen, the liver, the spleen and the kidney, they are full of blood. If we are making any incision on the parenchyma of these organs, they bleed profusely. So unless and until it is mandatory, division of isthmus is not the treatment of choice in horseshoe kidney, right? We should just continue treating the UTI with antibiotics, or if there is a stone developing, then we can take out the stone. Division of isthmus is not the routine treatment done in horseshoe kidney. Now let's take a look what all is written in the workbook. Horseshoe kidney, the incidence is 1 in 900. This is a pair of ectopic kidney. There is fusion of medial subdivision of lower poles of both the kidneys. This is due to inferior mesenteric artery. Inferior mesenteric artery is present at the level of L3. So in horseshoe kidney, the level of isthmus, what we find, this is at L3, L4. If you have to choose one, then L4 is a better answer. Usually in horseshoe kidney, the patients are asymptomatic. Rarely, patients can present with symptoms like swelling and pain, and here the swelling and pain is not in the bilateral lumbar region, but it is in the lower abdomen. Sometimes complications can occur like UTI and urinary stones. If the patient is presenting with swelling, we do an ultrasound. Best is CECT. On IVP, we can find flower vase uretus. Flower vase uretus, which is demonstrated here. Or we can also call this as hand joining sign. Hand joining sign. In the treatment, if the patient is having UTI, we treat them with antibiotics. If there are stones, we do removal of the stones. Division of isthmus is not the treatment of choice in horseshoe kidney. Right? Fine. So here what we'll do, beta, here we are done with the lumbar region also, where we talked about 4 things: absent kidney, ectopic kidney, polycystic kidney and horseshoe kidney. Absent kidney, 1 in 1000. This is due to renal agenesis. Ectopic kidney, 1 in 400, when the kidney fails to ascend, most often seen on the left side in the pelvis in the retroperitoneum. Polycystic kidney disease can be 2 types, congenital or adult and infantile. Congenital adult is more common. It is autosomal dominant. Infantile is autosomal recessive. It is rare. It is associated with high mortality. Generally, what we come across is the congenital or adult polycystic kidney disease, which is bilateral, can be associated with cysts in other organs, most commonly the liver. However, cyst can be seen in the spleen, pancreas, ovaries. It may be associated with Berry aneurysm of circle of Willis and mitral valve prolapse. Clinically, the patients manifest after 30 years of age. Generally, there is swelling and pain in bilateral lumbar region. There may be hematuria, hypertension in 75%, and uremias. In clinical approach, for a patient presenting with swelling, first investigation will be ultrasound. Best would be CE-CT. We can do IVP or IVU where we find spider leg appearance. In the treatment, initially we try to decompress the cyst by de-roofing of the cyst, but eventually both the kidneys fail and we land up in doing a kidney transplant. Whenever we are doing a kidney transplant, we prefer taking left kidney from the donor due to long left renal pain. And this transplanted kidney in the recipient is placed in the iliac fossa, that is at a different anatomical location, which we call as heterotopic transplant. If we are placing the transplanted organ in the same anatomical location, we call it as orthotopic transplant, like we are doing for liver. The various contrast studies we discussed in the GIT, esophagus, swallow, stomach, meal, duodenum, jejunum, ileum, meal, follow through, and colon enema. In the urinary tract, upper urinary tract, kidney, ureter, IVP, IVU, antegrade, retrograde pyelography, lower urinary tract, bladder, urethra for bladder, cystogram, cystography for urethra, retrograde urethrogram. Two pathologies where we have to do micturating cystourethrogram or voiding cystogram, posterior urethral valves, and vesicoureteric reflux. Horseshoe kidney, the incidence is 1 in 900. This is just a pair of ectopic kidneys due to fusion of medial subdivision of lower poles of both kidneys due to inferior mesenteric artery and the isthmus of the horseshoe kidney, that is the fusion of the lower poles of the two kidneys, that is lying at the L3, L4 vertebral level. If you have to choose between L3 and L4, L4 will be a better answer. Usually these patients do not have any problem, but sometimes there may be swelling pain in the lower abdomen. Sometimes UTI and stones can occur. In the treatment, we just treat the complications. Division of isthmus is not the treatment of choice. However, if the patient comes to us with swelling in the lower abdomen, we do ultrasound. There we can come to know about this horseshoe kidney. Best would be doing a CE-CT of the abdomen, and when we are doing a contrast study here, we see the flower-based ureters or the hand joining sign. Right, beta. So what we'll do now is we'll take a break here, and what should be done? Should we take a lunch break here? Or, yeah, let's take a lunch break here. And let's be back at 2 p.m. Thank you very much for your patience. And I would be responding to your queries also, right? So we'll be stopping the stream and we'll be starting the 2 o'clock class with a new link. Right? And I would be responding through the voice note to your queries on WhatsApp. Right? Thank you very much.